Good morning to all of you. On behalf of Government Medical Officers Association and Society for Health Research and Innovation, I warmly welcome all of you to the workshop on common skin problems and mistakes encountered in the OPD setting. This is our sixth CPD program, and today we have about 500 doctors registered with us for this workshop. And this is a 2-hour workshop done by Dr. Naini Madara Singh, consultant dermatologist at National Institute for Infectious Diseases and secretary for Sri Lanka College of Dermatologists. Please be kind enough to mute your microphones and your video cameras during the workshop. And if you have any questions, you can direct them to the lecturer by using a chat box. Now I warmly welcome Dr. Naini Madara Singh to start the workshop. Over to you, madam.
Thank you. Very good morning to all of you. First of all, I would like to thank the GMO Expo committee for inviting me to do this lecture today. And also it is very heartening to see this much of numbers. Yeah. Now we will move on to our topic, that is common skin problems and also the mistakes encountered in the OPD. So actually what I'm going to talk is like, as you may know that skin problems are very common in day-to-day practice. So I have identified few common problems, and also I will be highlighting the mistakes done by medical officers. Actually, please don't take this as an offense. This will be just a learning experience so that we can learn out of from our own mistakes. So before going on to the individual cases, I would just get an approach to a patient with skin disease. So skin diseases are usually like, dermatology is a visual specialty, and skin diseases most of the time can be diagnosed by inspection. But sometimes this may be just the manifestation of an internal problem. Therefore, proper history taking and examination is important in order to arrive at a proper diagnosis. Therefore, the general background of the patient, and then the points specific to the skin disease, like any other associated factors like itching or burning sensation, and then the onset of the rash and how the rash has progressed. All these things are important. And then the associated factors, like for example, if a patient comes with acne, we have to ask about any other associated factors like menstrual irregularities, hair loss, hirsutism, just to find out whether there's a hormonal cause underlying this acne. And also the other most important thing is impact on quality of life. So as you know, skin diseases are visible, and also there's a big stigma associated with these skin diseases. Therefore, it may affect the patient's quality of life, and there will be can be profound psychological impact. Actually, even in my experience, I have come across 2 patients who have tried to commit suicide just because of the skin disease. Therefore, it is very important that you take some extra time to see how much the disease has affected their quality of life. Then the examination. Good light is very important for dermatological examinations. That is what we say is usually direct sunlight. And then the proper exposure of the patient is important, because sometimes what we see when the patient is partially exposed may be completely different picture when the patient is fully exposed. Of course, we have to respect the patient's privacy when doing these examinations. So when it comes to the management of the skin disease, I think you will agree that patient expectations are always a cue. Like, although they are having some other diseases which can be controlled with medication, but when it comes to skin disease, they want a cure. And also there are so many people out in the market who will market a cure for most of the dermatological conditions. So we have to, if not a cure, we have to at least offer a comparable service. I would say that most skin diseases can be successfully treated and controlled. Although if it is not a cure, they can be successfully treated. And if we do this, our patients will not end up in this state. So now we will move on to the actual cases. Case number 1, a 45-year-old male presenting with an itchy skin rash for the last 4 months. This rash started in the groin and later involved the other areas. So these are the medicines that he came up with. So actually when it comes to skin problems, people have the tendency to collect all these empty tubes and boxes, which is sometimes a nuisance for us, but sometimes it can be helpful to know what the medication the patient has received. The diagnosis is tinea incognito. So actually tinea incognito is a big name given for just the tinea infections which have been previously treated for with topical steroids. Actually this is a mistake because tinea is a fungal infection. So we will just talk about few points about dermatophytosis. This is a disease of the stratum corneum of the skin, hair and nail, which is caused by a fungi called dermatophytosis, and it is commonly known as tinea or ringworm disease. Ringworm is the lay term. So modes of transmission, it is usually transmitted by close contacts. This close contact can be with infected animals or humans. And also it is transmitted with airborne hair, scales, fomites, and uncommonly by soil. And the important factor is that infective spores in this hair and dermal scales can remain viable for several months and even years in the environment. Therefore, proper disinfection and personal hygiene is very important to prevent a recurrence of tinea infection. Clinical features. So this is actually the typical tinea, like the typical skin lesion in tinea infections. So I think you know, you're familiar with this. These are annular erythematous plaque, and you can see the active edge with papules and pustules, and there will be central clearing because of this clinical feature only, because like a shape of a ring, they have got the name as ringworm disease. So depending on the site involved, there are different names for tinea infections like tinea corporis when it involves the body, and tinea cruris when it is involving the groin, which is a very common presentation, and tinea pedis. Actually, this can be missed because there are several forms of tinea pedis. I think you are familiar with this one with the white hyperkeratotic plaque-like lesions in the interdigital areas. And then sometimes uncommonly you see this scaly hyperkeratosis, and sometimes even this blistering vesicular type of tinea pedis as well. Then tinea manum is tinea involving the hands. Usually one hand is affected and one can get mild erythema, which may not be obvious in our type of skin, and scaly. This may be usually extension of the athlete's foot. When the person is having tinea on feet, they tend to get the tinea on hands as well. Tinea unguum is the tinea involving the nails. So usually one or two nails are affected and the nails will be thickened, discolored and friable. And also there can be like onycholysis, that is separation of the nail bed from the underlying nail bed, and also subungual hyperkeratosis can be seen. So now we will move on to the mistakes. I think I mentioned this earlier, that is the use of topical steroids. So why do we give topical steroids? Sometimes we see even after diagnosing the patient with tinea and like referring the patient to the dermatology clinics, still topical steroids are being given in the OPD. One thing is like it reduces the inflammation, and so I think it is given for the symptomatic relief. Actually, although this was practiced some time back, this practice is no longer recommendation because of the emerging therapeutic resistance in antifungal treatment for dermatophytosis. And also the other common problem is like steroid is given when the diagnosis is not clear. So what happens when we give a steroid to dermatophytosis? One thing, it will alter the clinical presentation. Therefore, I will give you the pictures later. Therefore, the subsequent diagnosis is going to be difficult. And also with the steroids, it will reduce the inflammation and scaling. Therefore, even for a test, it will be difficult to obtain skin scales for a diagnostic microscopical testing. And the other important thing is steroids will reduce the localized reduction of T cell mediated immunity and reduce force mediated inflammation. Therefore, what will happen is there will be ineffective elimination of the dermatophyte. Thereby, it will cause chronic, widespread, and difficult to treat lesions. Actually, this is the major problem that we are facing nowadays because of the topical usage of steroids in dermatophytosis. And actually, I am, yeah. So these are the clinical features like you can see. Now, initially I showed a lesion which you have a typical ring-like lesion. But when they are treated with topical steroids, what will happen is this ring is broken, and what you get is only a broken ring, and the inflammation would be masked. And but sometimes there can be aggressive inflammation with pustules as well, as in this one. And also I think you can see the hypopigmentation in this finger. So that is due to the side effect of steroid. So even if the patient does not say that the patient has received a steroid, by just by looking at this, we can see diagnose that it is a tinea incognito. The importance of knowing whether the patient was given a steroid or not is that if this patient has been given a topical steroids earlier, that requires longer duration of oral antifungals. So it is going to be a burden for the patient. This is another characteristic form which is known as ring within ring appearance, like you get concentric 2 or 3 rings with the usage of intermittent usage of topical steroids. This I think you can see like Endem is like a potent topical steroids, clobetasol. We usually not even recommend it for the face, but this has been given in this tinea faciae, and this is also again extensive tinea corporis. You can, I think you can appreciate there's minimal scaling and inflammation in this lesion, so sometimes it's going to be a diagnostic difficulty. So actually the usage of steroids, I'm not saying without any facts. We did a multi-center study involving representations on all provinces, like representations of the 9 provinces in Sri Lanka. And out of the patients who are presenting to the dermatology clinics with dermatophytosis, about 42% patients have been earlier treated with steroids. So when we went on to see from whom they had got this steroids. So it was not self prescription, it was not pharmacy. The major proportion was from the OPD doctors or by the general practitioners. So actually it is a failure of the medical system. It is partly we are responsible for not educating you all, and then I mean it is a actually it was very disheartening to see these results. So then actually because of this, the Sri Lanka College of Dermatologists took measures, like we were really interested in teaching, and also like we wrote to the NMRA about this triple combination creams. So because of this, from last year, the new registrations of triple combination creams are banned from the by the NMRA. So whatever that is there available in the market is the ones which have got the previous registration, but they will not be able to renew their license. So I think if you like you take it as a point not to use these triple combinations. I mean, they are of no use. So that will be a major achievement if at least this can be terminated from our practice. So then moving on to topical antifungals. Topical antifungals are usually recommended for single lesions, tinea cruris, which is not initially treated by steroids, and also when systemic drugs are contraindicated. So then the question is, which topical agent? Actually, there's no hard and fast rule. It can be variable. Usually, azoles are considered as a general first line. And also, if one is combining a topical antifungal and oral antifungal, it is always good to add uh, drugs from two different groups because that will reduce the resistance. Systemic antifungals indications are tinea capitis, tinea pedis, onychomycosis, and then extensive tinea corporis. Actually, the duration and dose will vary depending on the location, but usually a minimum of 2 weeks of oral antifungals are recommended, and there can be slight variations depending on the location. So then the question is, which drug can be used? So I think so. The next mistake is not giving the proper oral antifungal drug. So this is again an online survey done a few months back, involving 54 general practitioners, and the common used drug was fluconazole. I'm actually yet to see the questionnaires that y'all have filled up. So fluconazole we see quite commonly being practiced by medical officers for tinea infections, and the dose that is being usually being given is the 150 milligrams weekly dose. But when it comes to the prescription of systemic antifungals for dermatophytosis, what is recommended are itraconazole, terpenephrine, and cruciafilvine. Because of the low cost and the availability in our hospitals, we tend to give cruciafilvine, but sometimes you might have to give the other two commonly because of this drug resistance as well. Then what about fluconazole? So actually, fluconazole is not usually considered as effective for dermatophytosis. There are some studies which shows that efficacy with 50 milligram daily dose, not the 150 milligrams weekly dose that is being commonly practiced. And also, it is a worry that the frequent usage of fluconazole for dermatophytosis may in turn cause resistant strains of candidiasis developing. Therefore, please reserve your fluconazole in treating candidiasis only, not for tinea infections. Then the mistake number 3 is inadequate duration. So how long do we have to continue? This, of course, as I said earlier, will vary depending on the drug, depending on the site of infection. But it is important that we give the topicals at least 2 weeks post resolution of clinical symptoms. And then when it comes to oral, it varies depending on the site. So why I'm saying this is like there's emerging therapeutic failure for dermatophytosis. Like not like antibiotics, we have only three or four antifungals to deal with. So tinea becoming resistant to therapy is going to be a major issue. So these are the mistakes that we can do, to prevent, minimize this therapeutic failure from our side. So I hope you will take this into your uh, attention. So take home messages like diagnosis. If not sure, just treat symptomatically with antihistamines, not steroids, and proper and adequate treatment. And also you have to take measures to prevent recurrences and reinfection. Thereby, there the patient education is important and timely referral. Little bit about tinea capitis as well. Tinea capitis is the tinea infection involving the hair follicles. So it could be like a non-inflammatory tinea, which manifests as scaling and non-scarring alopecia. Sometimes, if a tinea, which is of animal origin, is the cause, you get an inflammatory tinea capitis, which is also known as a chirion. So what is the common mistake here is this is being misdiagnosed as an abscess, and the patient will end up with a large wound. So the treatment is actually topicals are not effective because we have to treat the hair follicle which is deep. So we have to treat with oral antifungals. And the important thing of why this is important to detect this early because chirion can end up with scarring alopecia. So early treatment will prevent the scarring alopecia from occurring. And when it comes to tinea, glycefulvin is the recommended, the drug of choice, and the dose is 10 to 20 milligram per kg per day. And we might have to treat this for a period of 6 to 8 weeks. So now we will move on to the case number 2. It's a 52-year-old female presenting with multiple leg ulcers which are painful and recurrent over last 3 years. Mistake number 1 is not diagnosing the cause of the leg ulcers. So there are many causes of leg ulcers, and the uncommon causes may be diagnosed only if they are suspected. So sometimes this may need a skin biopsy, can be helpful at times. So talking about the causes of leg ulcers, these are the common causes like chronic venous insufficiency, chronic arterial insufficiency, neuropathic ulcers, diabetes, and lymphedema. Then you have a whole range of uncommon causes of leg ulcers too. Although I say these are uncommon, they are not that uncommon because we see them in our day-to-day practice. So infections. When we talk about infective causes of leg ulcers, it can be many. Like it could be leprosy, atypical mycobacteria, fungal infections, and sometimes leishmaniasis. Malignancies, of course, you have to be vigilant to detect these. And then the inflammatory causes like pyoderma gangrenosum, vasculitis, connective tissue disorders, and rheumatoid arthritis. Livedoid vasculopathy is an vaso-occlusive disease. And then sometimes drugs like warfarin and heparin can give rise to leg ulcers. And there are other causes like hemolytic anemias and calciphylaxis. So talking about these uncommon causes of leg ulcers, pyoderma gangrenosum, I think it is like the typical feature is this bluish undermined edge that you see in pyoderma gangrenosum. These are like very painful ulcers. They start with like a papule or pustule and then rapidly develop into this ulceration. So apart from the usual management of ulcers, they will rapidly respond to like topical or oral steroids, and sometimes we have to go on to use the other immunosuppressants as well. So why it is important to diagnose the cause of the leg ulcer is the management is totally different because we have to treat the cause of this leg ulceration. This is vasculitis. Again, there will be painful punched out ulcers. So what we usually see as vasculitis is the palpable purpuric lesions involving the lower limbs. That is usually seen when the vasculitis affects the small vessels. But when it is occurring in medium vessel vasculitis, as in ANCA-associated vasculitis and polyarteritis nodosa, people can develop leg ulcers. So here again, the diagnostic factor will be the skin biopsy, and then the treatment will be according to the cause of the vasculitis. Then cutaneous leishmaniasis. I think for the people who are working in endemic areas of leishmaniasis like Polonnaruwa, Anuradhapura, and even down south, this may not be a problem because I used to work in Anuradhapura, and like even medical students were able to diagnose a cutaneous leishmaniasis as they enter the clinic. But like in other people in other areas may not be very familiar with cutaneous leishmaniasis. But leishmaniasis is nowadays not limited to those areas. Actually, it is seen all over in the country, and any ulcer which is not responding to maybe for the conventional treatment, we might have to think of this diagnosis, and these will respond very rapidly to intralesional sodium stibogluconate injections. So the management will be totally changing with the diagnosis of cutaneous leishmaniasis. Squamous cell carcinoma. So this is actually, we have to be very vigilant, and like any ulcer which is not responding and with everted edges, we have to suspect a carcinoma. Although you might say that we will not miss a patient like this, but this is actually a patient who has been getting treatment. Even now you can see the purplish color. Somebody has been trying to put tension violet as the ulcer management here. So we have to actually prevent this state of skin malignancy is being detected at this stage. It has to be detected way early than this. Livedoid vasculopathy. Again, this is not so uncommon because this occurs with in association with chronic venous insufficiency, and these are very painful punched out ulcers. And also in the background, sometimes you can see reticulate purpura and ecchymosis, and these ulcers heal with typical white porcelain-like scars. So here there can be an associated increased hypocoagulable state, and the treatment is usually with aspirin and antiplatelet drugs and sometimes even warfarin, or the treatment of chronic venous insufficiency. So then apart from the causes, now we will go on to the mistake number 2, that is giving antibiotics inappropriately. So as you know, antibiotics do not heal ulcers, and too much antibiotics may cause resistance. So antibiotics should be reserved only when there's clinical evidence of infection is present. So there's actually, like when we take, there's a thing called infection continuum. So like any chronic ulcer may be having some amount of microorganisms in the ulcer. So it could be either contamination or colonization. So in these two states, actually the microorganisms are living in harmony with the ulcer environment without causing any further damage or impedance to the wound healing process. But when the microbial virulence or the number is increasing, it becomes into this stage, that is the local infection, and then it can spread to the surrounding tissue, and it can even cause systemic infection, which needs systemic antibiotics. So antibiotics are actually indicated only after the third stage, that is the local infection. So how do we diagnose? Like this local infection could be either covert infection or overt infection. Actually, the covert infection is the most important thing because that is the turning point. We have to be very vigilant to identify at this point. And even this covert local infection can be managed without antibiotics with rotational dressings and antiseptics. But we have to manage it quickly and properly to prevent them moving on to the next stages. So if there's any fiber granulation, epithelial breaching and pocketing in granulation tissue, wound breakdown and enlargement, and delayed wound healing, new or increasing pain and increasing malodor, we have to think of uh, ongoing covered infection. So the infection, when you get the proper overt local infection, you get the all the features of cellulitis with erythema, local warmth, swelling, and purulent discharge. So this is the period that actually should be managed with either, sometimes even topical antibiotics would be enough if it is a mild infections, but sometimes oral antibiotics are needed. Few words about biofilms when I'm talking about the wound ulcers. So biofilms are seen in many chronic wounds. Actually, this is a complex collection of organisms which are bound together in extracellular matrix. So when there's a biofilm, they are less, the wounds are like covered with this, and we need to do wound debridement because it is less susceptible to antiseptics and antibiotics. And also the occurrence of biofilm can delay the wound healing. So therefore, there is the place for mechanical debridement of the wounds, which is why it is important. Then the mistake number 3 is taking too many swabs for culture. So as I mentioned earlier, all chronic wounds may have some amount of microorganisms. So do we have to swab? Because there will be, anyway, there will be colonization and you will get a culture positivity. So if it is a mild infection, actually we don't have to do a swab. We can just treat with the conventional antibiotics. But swabs are needed when the ulcers are not responding to the initial antibiotics and when atypical organisms are suspected. And also, if we were to do a swab, we have to take the swab in the correct manner with proper wound healing, and then we have to take a deep swab. And otherwise, what we will get up the culture positivity is the just the colonizing organisms. So this is example to show that wounds do heal without antibiotics and swabs. So I think we have come to the case number 3. This is a very common presentation. It is a 32-year-old female presenting with increased hair shedding over the last 3 months. And I would think that hair loss is a very common presentation both to the primary care physicians and dermatologists. And of course, for us, like even more than 75% of the patients will have hair loss even as a subsidiary complaint. And this can have a profound psychological impact for the people as well. So this is a vulnerable population. Therefore, there are people in the out there in the market who will like to grab this vulnerable population. Therefore, like I mean, as healthcare professionals, we have to do a proper job, and also we should be able to give the proper advice to the patients. So mistake number 1, not detecting the normal hair loss. So as I said earlier, like this is a very common complaint. So is all these patients who are coming with hair shedding, are they having a significant hair fall? Most of the time, not. That is because now the hair grows in a cycle, and like there are 3 phases. Like it is an anagen phase, that is the phase that the hair fiber is increasing in length, and depending on the length of the anagen, the length of the hair will vary. And then the hair goes to a form which is called a catagen. That is a transient phase of 2 weeks. There the hair the cell apoptosis stops, and the hair follicle releases from the beneath dermal papilla, and then the hair comes to a phase called telogen. That is the resting phase, and after this telogen phase, which is usually 3 months, the hair will fall, and there will be another hair follicle which is coming up. So this cycle continues, and when we take a scalp at one given moment, about 80 to 90% of our hair will be in anagen phase, but there will be about 10% of the hair which is in the telogen, and this hair should fall for the new hair to come. So if a patient is having even 50 to 100 hair shedding per day without any hair thinning, that is a normal phenomenon, because there will be any day about 10% of the hair should are in the telogen phase, which should shed. Then mistake number 2, not identifying the cause for the hair loss. Most of the time we think that vitamin deficiencies are the only cause for the hair loss. It is not. So I would be talking about diffuse hair loss because this is the most common presentation, mostly in females and sometimes in males as well. These are the common causes of diffuse hair loss, like acute telogen effluvium, chronic telogen effluvium, diffuse alopecia areata, and androgenic alopecia. So telogen effluvium, the what we call as acute telogen effluvium, is like the increased shedding of telogen hair over a short period. So I mentioned earlier that the hair grows in cycles, and there's a phase called telogen. So when there's an acute stressful event such as a surgery or even severe viral infection, I think we see this mostly after severe dengue infections and even childbirth, the hair will automatically it will go to the telogen phase. So it will be not be that 10% that I mentioned earlier, even 80 to 90% of the hair can turn into the telogen phase. So 3 months, the telogen phase is usually 3 months. So 3 months after this telogen phase, this hair has to fall. So this is what we see as like now 3 months after the childbirth, people come and say when the baby is smiling, the mother's hair is falling. So that is a very common misconception. So likewise, sometimes people can't remember this acute stressful event which has happened 3-4 months back, but they just come with the hair shedding. So this hair shedding is reversible. It can be quite alarming because, large amounts of hair can be shed, but it is reversible. So we have to reassure the patients, and it usually lasts a period of less than 6 months. Then you have the other variety, that is the chronic telogen effluent. There again, it is the shedding of telogen hair, but it lasts longer than the normal 6 months. And the onset is not so acute, it is a slow onset, and also one can't identify a inciting event. Actually, chronic telogen effluvium is the commonest cause of hair loss in adult females, but sometimes this can be difficult to differentiate from early pattern hair loss. Actually, what we call as pattern hair loss is the balding process. This happens both in females and males, but in males there's a typical pattern, but in females you get this as a diffuse hair loss. So causes of chronic telogen effluent. Actually, this is the indication where we have to do blood investigations to identify the causes of hair loss. So like medical problems like SLE, chronic renal failure and liver disease. And then you have the hormonal problems like hyper or hypoparathyroidism. Then sometimes polycystic ovarian diseases, nutritional deficiencies like iron, zinc, calcium and vitamin D. And the drug history is also important because there are many drugs which are known to be associated with chronic telogen effluent. And sometimes there is a, as in any other entity, there's an idiopathic entity as well for chronic telogen effluent. Because there are so much talk about biotin for hair loss, I thought of looking for the evidence for biotin. I think this is being widely prescribed, and also patients take this over the counter. So when we look at the biotin daily intake, it is 30 micrograms per day, and we don't have our data, but in Western populations, typical dietary intake of biotin is between 35 to 70. So that is well above the daily adequate intake. And also, true biotin deficiency in healthy individuals is not known. So usually biotin deficiency is associated with malabsorption syndromes. And the interesting thing is there's lack of sufficient evidence for improvement hair loss with biotin, but still it is being widely used. And the usual biotin supplementation is 500 to 1000 micrograms per day. And I think you can see that in Sri Lanka, we have even 10,000 micrograms biotin capsules. So you can decide on your own, like the usage and the importance of giving biotin for hair loss. Then we come to another very important mistake, that is not identifying scarring alopecia. So what happens in scarring alopecia is scarring alopecia, the inflammation occurs in the hair bulge region where the stem cells are located. Whereas in non-scarring alopecia, the inflammation occurs in the bulb region. So in when the stem cells are affected with the inflammation, even if the cause is treated, the damage which is done would be going to be permanent, and they develop scarring alopecia. So how can we identify this scarring alopecia? So if we see a scarring alopecia, you don't see any hair follicle openings. But in a non-scarring alopecia, if you have a close examination, you can see, even if there are no hairs, you can just see the hair follicles. So this is actually, I think you will be able to identify the scarring here. You can see this shiny, glistening skin. And if you do a close examination, you won't see any hair follicles. So actually, although these two look more or less same when you just have a quick look, but these are two entirely different causes. One is a pseudopelade, that is scarring alopecia, and the other one is a severe pattern loss in a female. So the management is entirely different, and on scarring alopecia, we need to act quickly. So why it is important to identify the scarring alopecia is that once the damage is established, it is going to be irreversible. So we have to act quickly and treat the cause to prevent the and minimize the hair loss. And sometimes scalp biopsies are needed. Then we come to mistake number 4, and I think this is just just for information. That is like assuming there's no treatment for androgenic alopecia. So we should be educated to treat our patients and to direct them. Now, most of the time, if androgenic alopecia, that is a normal balding process, if it is treated early with topical minoxidil, you can see excellent results. So these are actually some examples of even advanced hair loss which have been treated with minoxidil, anti-androgens, and sometimes with platelet-rich plasma therapy, and you can see the improvement is quite obvious. So it is not a disease that there is no treatment. Yeah. So we have actually finished about 3 cases. So I would just think that it would be good to take a small break, and then we will be continuing with the other cases later on.